Support for Heroin, a Commonwealth Crisis, comes from Caron Treatment Centers, operating a facility in Wernersville, Pennsylvania, focused on a 12-step recovery program with a clinical component. Information at caron.org or on Twitter at Caron Treatment. Health South Nittany Valley Rehabilitation Hospital, providing inpatient and outpatient services for illness or injury. Health South for a higher level of care. NittanyValleyRehab.com. White Deer Run Treatment Facilities, providing all levels of care for drug and alcohol addiction. 24-hour-a-day admissions at 866-769-6822. Learn more at whitedeerrun.com. And from viewers like you, thank you. From the Outreach Building on the University Park campus of Penn State University, this is Heroin, a Commonwealth Crisis, with host Patty Satalia.
Good evening, and thank you for joining us for Heroin, a Commonwealth Crisis. I'm Patty Satalia. Heroin use in Pennsylvania has reached epidemic proportions. Once thought to be strictly an urban problem, these dangerous drugs are now readily available in rural and suburban neighborhoods, and young people are at particular risk. Tonight in this live statewide program, our panel of experts will explain what led to this deadly health problem and provide information on prevention and treatment. They'll also take your questions. Our toll-free number is 1-800-543-8242. You can also email us at connect@psu.edu. You may also tweet your question or comment to @WPSUConnect and use hashtag PA Heroin Crisis. Now let's meet our guests. Dr. Ward Donovan is medical toxicologist and professor emeritus of emergency medicine at the Penn State College of Medicine. Dr. Joseph Troncalli, medical director at the Retreat of Lancaster County, a private drug and alcohol treatment center. The Honorable Nancy Butts, president judge of Lycoming County, and Allison Turley, prevention coordinator at the Center County Youth Service Bureau. Thank you all so much for joining us. I'll begin with you, Dr. Troncalli. How has what's been described as Pennsylvania's heroin epidemic touched you personally? What brings you to this conversation?
Well, I'm a medical director for an alcohol and drug treatment center that's 140 beds in Lancaster called the Retreat. And I've been in drug and alcohol treatment for about 15 years. And what I see now is there's a trend towards more and more young people coming in for opiate detoxification and treatment. It used to be that there were probably about 50% alcohol and 50% other drugs and that sort of thing. We feel that it's kind of swung to about 80% opiates and maybe about 20% other drugs.
And when you say opiates, and we'll talk more about this, you're not just talking about heroin, you're talking about prescription drugs.
Right, pain pills, anything that we would consider an opiate or an opiate-like narcotic.
All right, Allie Turley, what brings you to this conversation?
Sure, I work at the Center County Youth Service Bureau, which is a local nonprofit agency in Center County, and we provide prevention services for kids and families in our area. So we're working with kids to help them learn the risks associated with using drugs and alcohol, and also to help support families and teach parents how to talk with their kids about drugs and alcohol so that their kids can grow up happy and healthy.
And we'll be talking more about that. Dr. Donovan.
Well, I'm a medical toxicologist, and I direct a inpatient toxicology treatment program at Pinnacle Health Systems, primarily Harrisburg Hospital in Pennsylvania. And I've been a toxicologist since 1986, and was previously mentioned, it wasn't until about the last 10 years that we saw this just huge epidemic increase in the abuse of opiates by not only young people, but by the middle-aged. And I treat those patients who do manage to survive in the hospital. The second reason I'm here is, unfortunately, a personally tragic one. I lost my only son to a prescription opiate overdose.
So you know this firsthand. Dr. Butts, what brings you to this conversation?
Well, I'm the only non-medical related person here. I'm the president judge of Lycoming County. I'm our treatment court judge. I have been for the last 17 years. We have a drug court and a DUI court, so we see not only drug-related offenses, but also DUI offenders now abusing prescription medication as well as heroin. And then last September, there was kind of a call to arms in Lycoming County, and I brought together a number of people across the community to come together to sit down and discuss the issue. And we've had a number of meetings, created a task force, created a steering committee. We've been doing outreach, gatherings, education, whether they be at school or town hall meetings. And so I've kind of taken two roles, one as seeing it on a day-to-day basis as a judge, a presiding judge, but also as what I perceive to be my responsibility as a leader in the community to bring people of all experiences and interests together, to come together to put aside the issues of turf wars and deal with the issue.
Running a drug court is a completely different responsibility, and not every judge is willing to take that on. Why, in your opinion, is it worth it, and has it paid off?
Well, I think some judges feel in some ways that they're being like a social worker, that when you go into the law, you're an advocate, and when you're a judge, you're still involved in primarily the law. When you're involved with a treatment court and you're aggressively involved in it, it's not just presiding over a legal case or, a criminal justice case. You have to be familiar with treatment modalities. You have to understand motivational interviewing, which sometimes we learn by doing and not necessarily by training, so that you have to engage the participants. You have to reach out and understand why the treatment provider thinks you should recommend for this participant they do that. It's not just somebody telling me, okay, now do this to them. You have to, it's a one-on-one conversation with a participant that you have to basically on the fly come up with a plan sometimes.
But are you seeing what's happening nationwide with drug courts? A lower recidivism rate, a second chance for people to straighten out their lives, and savings to taxpayers?
Absolutely. They say you can save anywhere from $1 to $7 per person per day with treatment court, as opposed to the traditional put them in jail, there's no treatment provided in there, no counseling, where when you're working with someone in treatment court, they're not in jail, you get them either involved in intensive outpatient or a partial hospitalization program. You see them every other week. You get them to break away from the people, places, and things that kept them locked into this cycle of addiction and show them a different way.
Dr. Donovan, what happened in the 90s? There was an aggressive push for doctors to treat pain more aggressively. What impact did that have on this whole opiate problem that we see not just in Pennsylvania but nationwide?
That's an important point, and is really the origin of much of our problem. The use of prescription opiates became not only more widely accepted, but even highly encouraged, to the point where I think the pendulum swung too far. And now there is widespread prescription misuse and abuse and miswriting by physicians across not just the Commonwealth, but the country. Those drugs make their way to the medicine cabinets of homes, and both the young people and middle-aged people as well get into them. They're more widely available on the streets because they're diverted. People obtain these prescriptions under sometimes false pretenses of having pain, and then sell those drugs on the street. I'm sure that the drugs that killed my son, for example, were obtained through false pretenses and then sold to him by the dealer.
Why, Dr. Troncalli, have so many people switched from these prescription drugs to heroin? And what difference does it make to the human brain whether you're taking a prescription opiate or heroin?
If I could just back up 1 second. If you start as a 12-year-old or something that's either smoking pot, doing alcohol, and that sort of thing in high school, what happens, there's a progression. If you could be a fly on the wall in my exam room, you would hear the same story over and over again. What's happening is that young people get started on whatever you want to call them, gateway drugs or whatever. Then pills become available to them, generally speaking, much easier than heroin when they're in a high school setting or something like that.
And then, we tend to think they're safer.
Well, they're definitely not.
Definitely
not, right. So, but what happens is there's a cost thing that comes into it, and they can't afford their pills anymore, and they can get heroin cheaper than they can get their pills.
I've read OxyContin on the street can go for $80 a pill, and you can get a hit of heroin for $10.
Right, it's about $1 a milligram for those of you who are keeping score, but but you can get a $10 bag of heroin, you know. So The point just being that it's a stereotypic progression for all these young people, and they basically come to a place where they go from using pills to snorting heroin to injecting heroin. And the one statistic that I'd just like to say is that if you are injecting heroin, you have a 64-time greater morbidity and mortality than the general population. It's not like 2 times, it's not like 5 times, it's 64 times. And so what we're dealing with is not just a drug epidemic, but it's a public health epidemic, and these people die. You don't see a lot of old heroin addicts.
This used to be considered, drug use, heroin use specifically, Allie Turley, used to be considered sort of a solitary activity. It's now become a social thing among teens.
We absolutely see that. Oftentimes, kids tell us, we do a lot of surveying of kids so that we really understand where they're coming from, what their experience is, and oftentimes what we're seeing is that kids don't think that they're going to become addicted to these substances. They don't think that they're going to be that person who is seeking, heroin in an alley and shooting up. That's just not a reality for them. So when they start experimenting and having those early experiences with drugs and alcohol, it's really fun, and it's what they do socially, and it's what their peer group is doing, and then that kind of addiction kicks in, and we see kids making really poor choices.
You say one of the problems that parents make is normalizing that activity, saying, "Oh, this is a rite of passage. We all did this." Right.
Absolutely, and not really understanding the degree to what their children, are using and how often they're using it. This isn't, drinking a beer one time in their lifetime before the age of 21.
What's the likelihood, and then I'll take our first phone call, but Dr. Donovan, what's the likelihood if you use opiates as prescribed that you'll develop a problem?
If you're using them as prescribed, you still are going to develop a dependence on that drug. And many of the patients we see become accidentally, through no fault of their own, addicted to these drugs, and develop a gradual and increasing tolerance and needing more and more of the drug to achieve the same result, to the point where they finally are using so much that they do develop serious health problems and end up oftentimes in my hands in the emergency department in the critical care unit, suffering from an opiate overdose.
Can you talk a little bit about something that's new we've recently just heard about, although not to you, new in the emergency room, but an antidote to overdose that we're reading so much more about, Narcan, which can be used as a nasal spray, or the injectable.
Yes, I'm glad you brought that up, because it allows me the opportunity to plug some legislation that's currently being considered in Pennsylvania. Naloxone, and its brand name is Narcan, is the antidote for an opiate overdose, and it's extremely effective, up to 100% effective if used early. And that's the point, it must be used early. And of course, naloxone is something that has been around since I began practicing medicine, which is more years than I care to say, in the emergency departments, and it's only available in the emergency departments, from paramedics, and of course in the hospital. If this drug was available in homes, in homeless shelters, in prisons, in treatment centers, families and friends had access to naloxone, we would see a magnificent drop, and it has happened. There are at least about 10,000 known survivors from home use of naloxone, because there are centers that are actually already distributing naloxone.
But there are governors, like the governor of Maine, who says, but this is just an enabler. This will allow people to go out and use drugs.
Actually, that's been shown to not be true. Where naloxone has been made available to the public, actually there's been shown to be a decrease in the use of naloxone. It is not an enabler, it is a lifesaver. The House bill in Pennsylvania is House Bill 2090. It's been moved out of committee, and potentially, we hope soon, will come to the floor to be voted on in the House. I encourage all of you to contact your state representatives and ask them to support House Bill 2090, the legalization or availability of naloxone to the public.
Is a lifesaver. All right, we go to Debbie, who's calling us from Harrisburg. What's your question, please?
Hi, my son is a heroin addict, and he feels that Suboxone is the only treatment for him. And he's going to a clinic in Pittsburgh. But what I see is he's paying once a week to see a doctor who's giving him a prescription, but there's no therapy involved. He doesn't have insurance. What other options do we have?
Dr. Troncalli.
I'd like to speak to that. Suboxone, just for the audience's sake, is an opiate analog. It's a narcotic agonist-antagonist, and it's not worth going into all the pharmacology with that. But what I just want you to understand is that the caller is correct in that if you're going to use Suboxone, it needs to be given in, and this is my opinion, but I believe my opinion is backed up by good science. If you're going to give somebody Suboxone, which would be like methadone or other opiate analogs, the reason that you would do that would be to keep the person free from cravings and that sort of thing. But the problem is that Suboxone, just like other opiates, has a street value. And so if people are not carefully monitored with the use of Suboxone, then what happens is that they can divert it just like they can divert other opiates and that sort of thing. I'm personally very much in favor of running a good Suboxone program if somebody needs Suboxone, but on the other hand, that needs to be carefully monitored, just like you would carefully monitor somebody with diabetes. You wouldn't give somebody insulin and not check their sugars. What happens now is that it's legal for some doctors, I mean, it's legal for doctors who have the special DEA certification to prescribe Suboxone, but if they're not doing it in the context like I'm talking about, where people are carefully monitored, it's just as dangerous.
But she sounds like she's also concerned that what about addressing the underlying problems that got him to use drugs in the first place, whether they're psychological, vocational, legal?
Absolutely. Again, I believe that Suboxone can be used if it's used in the context of a total treatment program. Unfortunately, it can be prescribed right out of the office, and there are a number of doctors across the country, Pennsylvania included, where people are just handing somebody a prescription for it, and basically it ends up getting diverted. Some people use it properly.
As abuse is what got them in trouble in the first place. It
is. It's a really complicated issue, and I don't think we have enough time to continue. To completely go into it. But I don't want people to either take it that Suboxone is a bad drug. It's not a bad drug. It just has to be used properly, just like opiates have to be used properly.
Okay, any advice for her
I would try to find a doctor or a clinic or a Suboxone clinic where there is other adjunct programs going on with outpatient therapy, frequent visits, drug testing, all these sorts of things, so that you know that the person's using the drug properly.
Wouldn't you also recommend that she also find out if there's a Nar-Anon or an Al-Anon meeting in that community as well, which supports the family members of those that are addicted? So it's possible through that connection that she could develop some resources that would enable her son to meet maybe a sponsor, to be able to be introduced to 12-step traditions and 12-step meetings, so that they can not just not use the drug anymore, but understand that there's a different way of life that you need to live.
And the reality is that 80 to 90% of people who go into rehab or into treatment will fail. It takes typically 3 times before people are successful. So it's a long haul.
Could I just say one other thing?
Sure.
I just wanted to say that it's very important for people to understand that there's a difference between heroin use and heroin addiction. Not everybody that uses drugs is an addict, and about 10% of the population are genetically predisposed to having addiction. So we see people who abuse substances and don't end up addicted to substances, and it's very confusing for people who are not familiar with the neurobiology of addiction to see people use it, and then they say, well, he's using it or she's using it and she's not addicted. But so anyway, it gives people a false sense of security.
Okay. We have a question from the audience. This one: what can family members of addicts do to help them gain strength and courage to fight their addiction? How can we support them best when they are at their lowest? We'll begin with you, Ellie Turley.
Sure. I think just recognizing that there is an addiction, that there is a problem that the family needs to address, and be really supportive of that program. Supportive, getting them to their meetings, supporting getting them to their appointments, their counseling sessions, monitoring kind of their prescriptions and things like that, and also having high expectations for what you expect from them. So, you know, whatever your family rules are for that, your family guidelines are for living in the house with you, and you know, what your role is in the family, and being really strict about following through.
Dr. Donovan, anything to add to that?
Well, my expertise actually is in the treatment of overdoses rather than the counseling and rehabilitation. But I would say mostly that if your family member, friend, is unfortunately involved in the law because of their drug use and has gotten into trouble with the law, drug courts are a fabulous resource and have the best success rates that we know of. And so, although it sounds perhaps cruel or difficult, in some ways, the addict is lucky to get into the arms of the law, to get into the legal system, and then be fortunate enough to live in a county where there's a drug court system.
I want to follow up on that in just a moment. Thank you for tuning in to Heroin, a Commonwealth Crisis. Our panel of experts is ready to answer your questions. Our toll-free number is 1-800-543-8242. If drug courts are so successful, I wonder why only a fraction of those 1.2 million drug-addicted people actually have access to one.
Well, as we talked about earlier, some counties, the judges don't feel comfortable. They don't feel like they're able to manage the population. Sometimes the individual has to choose it. At this point, at least in Lycoming County, we don't order people into treatment court. And many people, they spend a month, 2 months, 3 months in jail. They haven't used in that period of time. I've got this kicked. I don't need this. It's not a problem. They are released, you know, they're sentenced, or they go through the system and they don't involve drug courts as part of their sentence or any kind of treatment component. They go out, they start hanging around with the people, do the things that they used to do, and hang around at the places they used to be, and they just get sucked right back in.
How do you respond to critics who say the problem with drug courts is that they're inherently coercive, that you're not going to be as successful with rehabilitation if you've been made to do this as opposed to volunteered?
Well, I think I can argue both sides. I can tell you that statistics show that there's a slightly better success rate on people that are ordered into treatment than those that volunteer for treatment. But from our perspective, we're a post-conviction program, so that an individual that comes in with us is either on supervision already and has still an addiction problem that we then kind of bring them in and put them through our program, or they plead guilty, which they have an absolute right to go to trial. We don't take that away from them. They come to us and choose us. And then once they choose us and they meet criteria, then we accept them in the program.
All right, we're going to take another phone call. Is John from McKeesport still on the line?
Yes. Here is my question I would like to ask. About 7, 8 years ago, I had a minor back operation, and I was plied with drugs. Now I am in a outpatient Suboxone clinic. What I'd like to know is, how is it that when you go to these clinics that usually are run by a bunch of retired doctors, if you have no insurance, you are paying close to $200 a month for a prescription of Suboxone, and that isn't even counting the $13 a piece it costs to fill it. You would think they would give this stuff away for free instead of, I mean, what addict can come up with this kind of money to buy this kind of stuff to stay off of dope?
Dr. Troncalli.
That's my question.
Thank you.
It's an excellent question. We actually had a drug task force meeting this morning in Lancaster County, where they were trying to talk about these sorts of issues. See, everybody's in a silo. Pharmaceutical companies make money. Doctors make money. Everybody, it's all money driven, unfortunately, both on the side of, you can be a drug dealer or you can basically prescribe drugs. I'm not impugning physicians in general or across the board or anything like that. What I'm trying to say is that when there's money involved, there's problems involved with it. For this gentleman who was calling in, what I would just say to him is that the cost of the drugs is not controlled by the doctors that are prescribing it. Again, we have a bigger systemic problem. If we're going to try to subsidize Suboxone, I have no problem with that. It's just that somebody's going to have to pay for that. I think we could also talk at great length about how this whole Suboxone thing came about, and again, there's probably not enough time to discuss.
Well, I guess my question is, how long do you anticipate that someone like John, our caller, would need to be on Suboxone? At what point could he be weaned from any assistance? Well, again, it varies on the individual. What we're trying to prevent is that business of people going to the streets and killing themselves with opiates. If the person needs to stay on Suboxone to keep themselves alive, obviously, however much money that was, which again, I'm not justifying, I'm just saying that's cheaper than a funeral. The problems that we see with getting people off of Suboxone is the same problems we see as detoxifying people from other opiates. It's not a pleasant process. It does take time. It takes a lot of resources to get people weaned down. We do it. I have a family member that was on Suboxone, is not on Suboxone anymore. I consider Suboxone something that has saved my family member's life. But it was not an easy process. It took a lot of very careful treatment and that sort of thing. So it can be done. It's just a difficult problem. It was pain that brought John to his problem, and that brings me to this question, Dr. Donovan. There are many who say that this goal of zero pain is a dangerous and an unrealistic one.
Yes, I certainly agree with that. There are many ways to treat pain, and too often the doctor just reaches for a prescription and often is forced because of time constraints now on physicians. It's a lot easier to reach for that prescription, write a prescription for an opiate, than to counsel them about the other methods for pain treatment. One excellent resource is a good, reliable, ethical pain management center. There are pain management centers that are simply nothing more than opioid mills. There are others that do an excellent job of treating pain without the use of heavy use of opiate prescriptions.
Could I say one other thing? There's a famous pain doctor in Philadelphia, Dr. Ashburn, who has shown that once you get past 120 milligrams of OxyContin, you're not going to treat pain anymore. You're basically just going to develop tolerance. And so, again, a lot of doctors and people who treat pain or trying to treat pain don't really, again, understand pain as well as they probably should. All right. If you're just joining us, I'm Patty Satalia, and this is Heroin, a Commonwealth Crisis. Let me reintroduce our guest. Dr. Ward Donovan is medical toxicologist and professor emeritus of emergency medicine at the Penn State College of Medicine. The Honorable Nancy Butts, president judge of Lycoming County. Dr. Joseph Troncalli, medical director at the Retreat of Lancaster County, a private drug and alcohol treatment center. And Allison Turley, prevention coordinator at the Centre County Youth Service Bureau. You can join the discussion by calling our toll-free number 1-800-543-8242 or by sending an email to connect@psu.edu. You may also tweet your question or comment to @WPSUConnect and use hashtag #PAHeroinCrisis. And we'll go now to Tim, who has been patiently holding on in Penn Hills. Thanks so much for your call.
Hello.
Hi, what's your question for our panel?
I'd like to thank everybody that's on the panel. And my question is, if there's a couple that's addicted to heroin, using it on a daily basis, and one of them passes, whose fault is it?
Well, I'll...
Hello?
Yes, well, we're here.
Yes, we're here. Again, we're not here to sort of blame anybody. It's just like, again, if we could just get the concept that addiction is a disease, and understanding that both of those people have a disease, and that one passed away because of their disease, it would be no different than if two people smoked and one of them had a heart attack, in my mind. I mean, I don't know if that's a good analogy or not, but all I'm just trying to say is that this whole thing with addiction is, and treatment of addiction is not about laying blame. It's about getting people adequate treatment and trying to keep people safe.
And one of the things that we should also say that Dr. Donovan talked about, the House Bill 2090, it's not just about Narcan, it's also Good Samaritan legislation as well, which is,
yes.
Go ahead, I'm sorry.
Well, Good Samaritan allows you to make that phone call to 911 so that you don't have to watch a loved one die. Correct. Because you're afraid that you're going to be prosecuted for using drugs.
And I think that's an indirect answer to the question, in that if you see a situation, you need to call for help and not have to worry about the possible ramifications that could happen to you, that the police could arrest you for something.
So what is the status of the Good Samaritan law in Pennsylvania? We don't have one, do we?
Not for this particular issue, but it is tied to the Narcan legislation.
Okay.
And I'd like to add comments about the addiction and whose fault it is, and the expense also. And it all goes back to, and I'm not afraid to say this, that the health insurance industry is complicit in the addiction problem that we have. It is not looked upon by health insurance companies, I think, still as a disease. It's looked upon as a personality disorder, and they are actually allowed to place limits on the duration of treatment and how much they will spend and how long people will be hospitalized. We would never dream of limiting the number of treatment visits, hospital stays for someone with diabetes, for example, and yet we do for addiction.
Actually, there is a mandate, and it's rare in Pennsylvania, that commercial insurance providers must provide 30 days of inpatient rehabilitation and 45 with a doctor's order, but it's not always honored.
It's
not honored.
No.
It's not neither honored, nor is it enough.
Nor is it
not enough.
And sometimes even accessing that insurance is a slow process. So sometimes that's why people get involved in the criminal justice system, because you get arrested, presumably you're going to be in jail, you're going to be abstinent while you're in the county prison waiting for your insurance to kick in.
Right, and the insurance won't cover you because your urine is clean now.
Correct.
And so you don't need detox anymore, but you suffered through detox. And then I'd just like to say, just like what we were just talking about, if diabetics had their pancreas in their brain, there'd be diabetics in jail.
Right.
You know, in other words, it's the same thing. You know what I mean? If you we just look at it as, because it's a brain disease and it affects behavior, then it's a bad thing. No other disease is thought of that way because it doesn't affect behavior. So because of that, it's stigmatized.
And of course, one of the most dangerous periods for a drug addict is right after rehab. They go out, they think one last hit, and of course their tolerance has changed because they've been clean for 30 days.
Well, see, it's important to understand that brain chemistry only changes gradually. And so you're at the highest risk of relapse right after you've had some clean time. And the more time that you have away from your drug, the better chance you have of staying abstinent. And so that's why it's really important to get what we're talking about here with more time for treatment, because people don't all heal at the same rate.
And part of training as a judge, we've even been shown MRI scans of people who are a year out, 2 years out, 5 years out on addiction. And it's really not until you get that many years out that the brain actually starts to recover. So you really need a long period of time.
And 50% of crime, I'm reading, is connected, linked directly to drug addiction.
Oh, I'm sure in my county it's even
higher.
Probably about 85%.
Okay, I'm going to talk with Allie Turley in a minute about risk factors and how we can enhance protective factors. But first I'm going to take this phone call from Kristen in Duncannon. Go ahead, please, Kristen.
Yes, thank you. In the Susquehanna School District in Perry County, they start random drug testing in 5th grade for students that are involved with sports and extracurricular activities. Is that the answer?
I was just going to say, I believe that education is the answer.
Absolutely.
But go ahead.
I agree too. I think a really strong approach where schools are involved, families are involved, the community is involved, law enforcement is involved, and everybody's working together to solve the problem is the best answer. Drug testing might be a piece of that, but it's just one small piece. It could be a deterrent for some kids, but it probably isn't a deterrent for everybody.
Yeah, in some ways it sounds like it's criminalizing childhood. I think to some that's the way it could feel. You wanted to add something, Dr.
I was just going to say that drug testing is a small part. In other words, like if you have somebody that you think is at risk, or in other words, just like they do at places of employment, if you have some sort of reasonable cause, then drug testing can be very helpful. I don't necessarily favor just across the board drug testing just to be drug testing.
Well, the interesting thing about what our caller is saying is we're talking about fifth graders, but when it comes to heroin use, we're seeing that the age of first use is younger and younger. It was 26, the average age now is 23, and it's not unusual for someone 12 years old. I'm wondering if you've seen someone in their early teens, Dr. Donovan, in presenting at the emergency room.
I mostly see in the very young the use of prescription opiates.
That they got from a medicine cabinet?
Yes, probably the youngest heroin overdose I've seen was probably in the 12 to 14 year age group, but certainly it is being seen in a younger and younger population.
Okay, I'll take a phone call in a moment, but I wanted to get back to you, Allie, about risk factors and enhancing those protective factors. What can parents do?
Sure. So risk factors are the factors that make it more likely that kids will have negative outcomes or will see problem behaviors like drug and alcohol use. And it's really important to look at all of the ways that young people are affected. So kids' own resiliency and their own temperament play into this. Their peer group plays into this, who they're spending time with. Their family plays into it, their school plays into it, the community plays into it. And when we have high risk factors, when families aren't monitoring behavior, when they are not bonding well with their children, when they don't have high expectations for behavior, and when a young person's peer group is using, and they're a high-risk, sensation-seeking kind of kid, when we start looking at all these risk factors piling on top of each other, we can see more undesirable behavior, like using drugs and alcohol. So what we want to do in a community and with kids and families is really increase the protective factors. So those are the factors that are going to make it more likely that this kid is going to make it through and make good choices. So families that have high expectations, schools that reward pro-social behavior, communities that really support kids who are making good decisions, those kind of things that keep kids really safe and connected to communities and bonded with people who care about them, adults who care about them, they're more likely to not use.
And this sounds like it's probably more effective than scare tactics. If you do this, this could kill you.
Absolutely. There's a ton of research around this scared straight idea, and it just doesn't work. Kids, they don't think that's going to happen to them, and that's not reality for people that they see. It's not reality necessarily for them, and you know, it just doesn't work.
It's harder and harder. I think a lot of parents would say it's harder to stay connected. Kids today have cell phones, so you know, when I grew up, my parents talked with my friends on the phone when they called to ask me to go out. That doesn't happen anymore.
No, and that's why guidelines at home are so important, and parents and other adults in the community who care about kids, they need to be involved and present. Just really mindful parenting skills, being really involved in what their kids are doing, knowing their kids' friends, knowing their kids' friends' parents, and making sure and following up on them. If a kid says they're going somewhere, go there and see that they're there. And oftentimes, you know, phones should not be in bedrooms. Computers should not be in bedrooms. That stuff should be turned in at the end of the night, because there's just so much access, just so much more. And we're basically just giving it to our kids.
And to add to this discussion, I'd like to interject is that parents can play a huge role in recognizing the changes in behavior of their children associated with the development of using drugs. Sudden changes, deteriorations in grades, changes of their friends to friends that are perhaps not as desirable as their previous friends, behavioral changes at home, obstinance, difficulty in their personality, and their interactions with parents. These are all warning signs that the drug use may be developing.
And what's so
I'm sorry.
I was going to say what's so challenging about that is we see a lot of those behavior changes in teenagers anyway.
Right.
So, you know, does my kid have a drug or alcohol problem? Is this just normal teenage things? You know, peer groups change and interests change. But recognizing that and having that really strong relationship with your child so that you can have those conversations and say, I'm really concerned about this. I'm noticing this. This is different. What's going on?
Oh, go ahead.
I was just going to say, but one of the things that we've discovered in our community is education for the parents.
Absolutely.
Is that it is non-existent because it's an inner city, different population problem. It's not in my backyard, it's not in my school district, and they're not even willing to understand what those signs and symptoms are.
And the new stats say it absolutely is in your community, whether it's a rural community or a suburban community, and in fact, 80% of those who are going in for treatment are white males, not people from cities.
Absolutely.
And I just wanted to say also that once addiction is identified in a teenager, for instance, everything switches around, and it's very difficult for parents to go from being nurturing to now having to use tough love.
Right.
And that's a transition that parents need to be taught as well, and it's a very difficult transition for them to make many times because they went from being, you know, close and all this sort of stuff, and then their child's lying to them and that sort of thing. Now they have to go and be very strict, tough, whatever it's going to take, get them into treatment, all those sorts of things. And so that's very hard on parents.
Because what we see is that by the time an individual gets arrested by the police for some crime outside the home, they have stolen from their parents multiple times, and the parents have either been afraid to hold their children accountable, or they just turn a blind eye because they don't want the police to know what's going on in their family. There's a huge sense of shame in the fact that this is touching my family and I don't want the world to know, and that really does everyone a huge disservice.
I'm going to take a Twitter question. This one I think we've sort of answered. What type of advocacy can Pennsylvanians participate in to help combat this problem?
My advocacy, or my belief, is that you need to get involved, and that's what we've done in Lycoming County. We've brought people together. We want them to not be afraid to talk about it. We have open town hall meetings where we bring experts in, and the feedback from these meetings is phenomenal about parents going, oh my gosh, I didn't even know what to look for. I mean, when I went to school, it was alcohol, it was marijuana, we would have no idea what to look for in terms of paraphernalia, the signs and symptoms that a person could be using. We are doing presentations at the schools for the SAD chapter, in support of the SAD chapters, or just for the teachers now who want to know what should we be looking for, because clearly...
In fact, you've started two committees in your heroin task force. One is youth and the other one is research. Why those two things?
Well, youth is because if we believe from our PAYS data, the surveys that we know that middle school is our appropriate target range, I'm old. I don't speak in the same language. I don't use the same social media that my son, who's 12, is already accustomed to. We need them to speak the language so that the youth will hear it. And that when we see them with their, you know, life is the anti-drug, or these great T-shirts that we know that they believe in, that we want them to spread the word. And we believe that that was the best way.
And that's part of the communities that care.
Absolutely. But also research in to collect the data to see if what we're doing is working, and if it isn't, how should we change it up, and what already evidence-based programs are there out there that we can bring into our community, to our schools, to our middle schools, to all of our grades, to be able to educate everyone.
All right, we go now to a question, this one from Amy, who is calling us from Ephrata. Go ahead, please, Amy.
Hi, yes. My question is, I have 3 children that age from 16 down to 10, and with the epidemic getting so big, I don't know how much information to give them. I mean, I tell them that, you know, drugs are bad, that this is going on. They've seen it with friends, children's going through things, but I don't know how much I should actually show them. Should they be sitting down, at least my 16-year-old, sitting down watching something like this to get the information to see that this is what can happen, this is what's going on out there.
Allie?
I would say absolutely. I would say, you know, all of your children, it would be appropriate. Yes. Absolutely. There's an age-appropriate level for this conversation, starting with kids as early as 3 and 4, but especially your 16-year-old. And it's really important for parents to understand that kids are getting their information from somewhere, and they should get it from you. So, you know, my guess is he could probably tell you more than you want to know about it, because kids, they experience this. This is their reality. So kind of not talking about it is really harmful.
I was going to say that the Betty Ford Foundation puts out a comic book for kids all the way down to like kindergarten to talk about addiction, because again, many children are affected by addiction, and they need to understand, they have to have some sort of a handle on it. So there is literature out there that parents can obtain to try to help educate their kids at an age-appropriate thing, so they're not having to, you know, watch this television program, for instance, but they have more age-appropriate sorts of materials.
And probably the question would be, who would we call? I would recommend to call the SCA, the Single County Authority, the Drug and Alcohol Agency for each county. Each county has at least one. Some counties share an SCA, and they can point you to prevention, they can point you to treatment providers, they can be a funding source for treatment if you're in crisis, but they would be the best resource.
I want to follow up on something you said earlier, and that was that families don't want to involve the police. They're ashamed that this problem has hit them. And yet, if you talk with someone who's using heroin, they say there is no stigma attached to using heroin today. It's not this back alley problem of the past.
I think there still is a huge stigma. It's along with any addiction, whether it be alcohol, marijuana, heroin, prescription medication, there's a stigma. The person is weak in moral character, and that if they really wanted to beat this, they could. And again, we refer back to if you're a diabetic and you really want to beat this, you can't just will yourself to be off insulin. You've got to have therapy, you've got to have treatment and lifestyle changes. Maybe you exercise more, maybe you eat properly, and then maybe you can wean off of insulin. It's the exact same thing with drug addiction.
Dr. Donovan.
I agree that there's still a huge stigma, and something that perhaps we should have emphasized in the beginning of this program is that addiction crosses all socioeconomic classes, all ethnic groups. And yet people often think that, well, this is only an inner city problem, and if it does happen in their children, they're embarrassed and they don't want it known, and they try to hide it. I also would want to emphasize, just to drive home how serious this point is, that as of 2008, there are more deaths from drug overdoses in the United States than there are deaths from automobile accidents.
And most of them from prescription drugs, not from illicit drugs.
About half of those are from either prescription opiates or illicit drugs, like, or a little over half, like heroin.
All right.
And also, people are using combinations of drugs which are quite lethal. In other words, people generally don't just use heroin, although some people do, but they start mixing benzodiazepines with their heroin. They start using other combinations, and the combinations are more lethal than just the single drug itself.
And what I understand is that the quality of the heroin that's available in Pennsylvania is quite high, quite pure, which really is a sign that it's quite accessible.
It's quite accessible.
We'll go to Richard, who is calling us from Pittsburgh. What's your question, please, Richard?
Why is there such poor law enforcement? You can drive around any city or town, and you can see drug dealers operating out in the open, day or night. In fact, they even advertise. They have a calling card. They hang a pair of shoes over telephone wires, and it tells you exactly where they are. And you can drive around your city, and you'll see that. Why can't the police be proactive and shut these people down?
Well, I know that in my community, when funding goes away, sometimes police officer positions go away. It would be great to have community police officers out there. Grant funding on the federal level for that has been gone for maybe 5 years or so. That's the way. That's the real way to solve this problem, is to be proactive, is to tell the world we don't tolerate this type of behavior in our community. So it would be great to have that. But realistically, whether it be the state police or your municipal police agencies, they're not going to be able to do it. So what you need to do is, as an interested neighbor, you have to make the phone calls. You have to be the eyes and the ears for the police and let them know what's going on.
And I'm wondering how many people in here knew that tennis shoes hanging over a telephone wire was a sign. A couple of hands went up.
Urban legend. It's not true.
Oh, okay, okay.
It's not true. Look it up on Snopes.
Okay, all right. So we will look that up on Snoop. And we'll go now to a phone call from Carolyn from Pittsburgh. Go ahead, please, Carolyn. Are you there, Carolyn?
Yes, I'm here. I have a question. I would like to know if OxyContin and heroin have the same chemical makeup.
Yes, they're opiates. There are differences in how long they last. Heroin, fortunately, I guess I have to say, has a very short half-life. That means it doesn't last long. A single dose of naloxone will typically save the patient who is suffering from a heroin overdose. But if it's an OxyContin overdose, they typically will need multiple doses of naloxone. So it's what we call pharmacokinetics, the duration of action of the drug, the onset of action. But in terms of its basic pharmacology, they're all opiates. And they work the same way, and the way they work is they depress respiration. They ultimately can cause direct lung injury. They can cause damage to the heart. It depends on how long the person survives or whether they recover, whether they're resuscitated successfully early. Many of the patients that we see end up in the hospital for days and weeks with what's called multi-organ failure. The opiate has affected every organ in their body because they've been comatose, unconscious, not breathing well, low blood pressure for hours and hours, and no one is there to attend to them and save them. And that's why I go back to, again, the concept of having naloxone in the home, in the community, where if there is someone who's knowledgeable about the use of naloxone and finds this individual, the earlier treatment it happens, the less likely they are to die.
And this naloxone basically tells your brain, breathe again.
Well, the naloxone just displaces the drug from what's called the receptor, the opiate receptor. And so instead of the opiate affecting that opiate receptor and causing respiratory depression, naloxone is essentially an inert drug that takes the place of that opiate and prevents the opiate from working.
How do you respond to those who say that this is just another crutch and another potential addiction, using some of these other drugs?
Using
Suboxone, for example, to get off heroin?
Well, Suboxone and methadone also, but I think particularly Suboxone have been shown to be safer than seeking drugs on the street. I often tell my patients, teach my residents, that you don't know what you're buying when you're buying something on the street. With the Suboxone, you know what you're getting, you know the dose, it's being hopefully prescribed in a controlled setting. And one advantage of Suboxone is that it has a threshold level where it reaches a point where it can't do any more harm. Methadone does not have that protection, and so I advocate Suboxone rather than methadone now as a preferred maintenance treatment program or maintenance treatment drug.
All right. I'd like to begin with you, Allie Turley, with your take-home message.
Sure. So I think take-home is that it is a community issue. It's not just a school issue. It's not just a family issue. Everybody needs to get involved and be aware of what's happening and educate themselves and really understand the facts and really get involved in being part of the solution. So joining local communities that care organizations, being involved with young people in the community, having high expectations for what you want in your community and what you want in your family, and make those choices that make that possible for your family.
Dr. Troncalli.
Well, the opiate epidemic is real, and beyond all the other problems that it causes, it kills people. And so it's very important for us to understand it as a part of the disease of addiction, and we need to do whatever it is that we can do to advocate for getting people the care that they need.
Well, speaking of the care that they need, most people spend more time picking a new car than they do picking a treatment center. So what should we look for?
Well, again, it's difficult to measure quality, but I think that, again, there's certain things that, like we talked about with the Suboxone clinics, if they're doing drug testing, if there's comprehensive care, if there's licensed professionals, all these sorts of things that you look for, and if you go to the American Society of Addiction Medicine website, they will help you make those kinds of choices.
Okay, Dr. Donovan.
I would answer that question not as a physician, but as a father, and I would go back to parents recognizing the potential warning signs that their children are getting into drugs, and then taking whatever it takes, whatever steps it takes to prevent further treatment, to treat the addiction if they do get into the addiction point. A previous caller talked about the expense, and then it was mentioned, well, it's cheaper than a funeral. So if you have to mortgage your home to save your child, do so. If you have to put your child in a difficult position of punishment and being placed in treatment programs that they may not want to go into, do it. In other words, tough love. Be aware of what's going on and do whatever it takes.
Judge Butts.
I think, just to follow up on what the doctor has said, I think you begin your child's life in that you set the standard. If you accept this type of behavior, then that's what you're going to get. And if you don't hold them accountable, then we're going to see them.
Okay. And we are out of time. Thank you to our guest tonight, Dr. Ward Donovan, Professor Emeritus of Emergency Medicine at the Penn State College of Medicine, the Honorable Nancy Butts, President Judge of Lycoming County, Dr. Joseph Troncalli of Lancaster County, and Allison Turley of Center County Youth Service Bureau. I'm Patty Satalia. Thanks for joining us. Good night.
Support for Heroin, a Commonwealth Crisis, comes from Caron Treatment Centers, operating a facility in Wernersville, Pennsylvania, focused on a 12-step recovery program with a clinical component. Information at caron.org or on Twitter at Caron Treatment. Health South Nittany Valley Rehabilitation Hospital, providing inpatient and outpatient services for illness or injury. Health South for a higher level of care. NittanyValleyRehab.com. White Deer Run Treatment Facilities, providing all levels of care for drug and alcohol addiction. 24-hour-a-day admissions at 866-769-6822. Learn more at whitedeerrun.com. And from viewers like you, thank you.